about epidemiology and comorbidities and risk factors, and then try to spend a lot of time on medications and therapy, and then we'll talk about prevention. Usually when I go to a talk about PTSD, I feel like what I really want to know is what to do about it, so I'm going to try to keep that the focus of what we talk about. But we do need to talk about the diagnosis. I like to think of things in terms of clusters, so there's really 5 key elements that you need for a PTSD diagnosis. The first is exposure, then intrusion symptoms, avoidance symptoms, cognitive and mood symptoms, and arousal symptoms. The key things to note is that it has to be longer than a month. It has to cause clinically significant stress or impairment and not be due to another medical condition or substance. If somebody has these symptoms and it's from 3 days to a month, then it would be considered acute stress disorder. So first is exposure. Excuse me. So this is to actual or threatened death, serious injury, or sexual violence, as evidenced by at least one of the following: either directly experiencing the traumatic event, so it's happening to the individual, witnessing in person an event as it's occurring to other people, learning that a traumatic event has occurred to a close family member or friend, or repeated exposure to the details of a traumatic event. And then it's intrusion symptoms. So you have to have one or more of these: recurrent, involuntary, and intrusive distressive memories, recurrent distressing dreams, either dissociative reactions. This could be like flashbacks or re-experiencing, where you feel like you're back in the traumatic experience. Distress at exposure cues that resemble the event. So you're in a situation that reminds you of the trauma and it causes significant distress, or you have a physiologic reaction to something that symbolizes the event. So maybe you develop a panic attack when you see or experience something that reminds you of the event. So these are the intrusion symptoms. Now, I often like to think about in the other core elements of PTSD developing in response to the intrusion symptoms. So avoidance symptoms are you'd have to have one or more of the following. You have an avoidance or an effort to avoid distressing memories, thoughts, or feelings related to the event, or an effort to avoid external reminders. This can be people, places, conversations, activities, objects, situations. So people's lives just get much more contracted and smaller because they're trying to avoid those really disturbing, intrusive symptoms, and they develop these avoidance symptoms as a result. Cognitive and mood symptoms can look a lot like depression, so it's important just to tease out when they started and if they started after the trauma versus if they were going on before. But you have a difficult time remembering aspects of the event, negative beliefs, distorted thoughts about the cause of the event, persistent negative emotional state, diminished interest, feelings of detachment and estrangement from others, and inability to experience positive emotions. So people try to just keep their mood states and their experiences really restricted so that they don't, like I said, experience those intrusive thoughts and experiences. And then arousal symptoms. So 2 or more of these, either irritable behavior, angry outbursts, reckless or self-destructive behavior, hypervigilance, an exaggerated startle response. So you hear a loud noise and you're jumping. Hypervigilance is really that, just being hyper aware of everything around you. People have problems with concentration and sleep disturbance. So you can have there's a couple of specifiers in the DSM-5. One is with dissociative symptoms. That can be depersonalization or derealization. That's a feeling, sort of an out-of-body experience, like you're watching something happen to you, or you feel like things around you aren't quite real. And there is delayed expression, so that would mean that full criteria isn't met until 6 months after the traumatic event. That is less common. More common, you see symptoms occur closer to the event. So the lifetime prevalence is 8%. In women, sexual assault is the most common trauma that results in PTSD. In men, it's combat. Interestingly, TBI is just a very strong predictor of PTSD. Even mild traumatic brain injury dramatically increases the risk of PTSD, especially in combat veterans. And then symptoms usually develop within 3 months of a trauma. Usually somebody will have acute stress disorder. That's distressing symptoms that we talked about within 3 days to a month of the trauma. So psychiatric comorbidities are really the rule. 50% of patients have 3 or more coexisting psychiatric disorders. And I know that I see this in my practice all the time, that most of my patients with PTSD have a number of other psychiatric illnesses as well. So people have major depressive disorder, substance-related disorders are extremely common, panic disorder with agoraphobia, generalized anxiety disorder, and other phobias, and somatic disorders. It is associated with a range of physical health problems that I listed below, and so PTSD increases your risk of a number of physical problems as well. So risk factors developing PTSD, the severity and proximity to the traumatic event seems rather intuitive. A history of prior trauma increases your risk of developing PTSD. A history of child abuse or those high ACE scores certainly increases your risk of developing PTSD. If you have another psychiatric disorder or another substance use disorder, that can increase your risk. Poor social supports, personality type, women more likely to develop PTSD than men, and again, the TBI increases your risk. So I am going to just talk a little bit about medications, but really when we look at PTSD, first line treatment for PTSD is therapy, and so I'll go over a little bit of the therapies. I like to think of the medications as being used as a tool to treat symptoms, really, so oftentimes people can benefit more from therapy. So they can help things like the depression or the hyperarousal or especially sleep. And if you can get those things under better control, I think people can benefit more from doing the hard work of therapy that really is the cornerstone of treatment for PTSD. So there's 2 SSRIs that are approved for the treatment of PTSDs, and those are sertraline and paroxetine. But really there's no necessarily reason to think that the other SSRIs wouldn't be as equally as effective. And the dosing recommendations are to do the same dose as you would for depression, although I would certainly say that if somebody has a lot of high anxiety or panic attacks, then I would probably push the dose. Venlafaxine and SNRI can help as well. Mirtazapine is a good medication, Remeron, for people that are having problems with sleep and appetite, usually at about 30 milligrams. Tricyclic antidepressants have been shown to be effective as well, although we have to be careful just because there's certainly a risk in overdose that's higher with tricyclic antidepressants. Amitriptyline, like at 25 milligrams, or doxepin at varying doses can help with sleep and nightmares. Trazodone also has shown to be helpful. Trazodone certainly can cause disturbing dreams in some people, so that's important to watch out for, but there's quite a range in terms of dosing of what can be helpful. And then second generation antipsychotics, Risperdal, Seroquel, and Zyprexa have been probably studied the most, but you know, because there's risks associated with those, metabolic risks and other side effects, I would really wait to start those until trying some other things. But certainly if somebody has a lot of aggression or violence, these would be worth considering, and they can certainly help with some of the hyperarousal or insomnia. The other medications that we use to treat PTSD, clonidine is used quite a bit. It's used a lot in kids for sleep, but it can really help with the hyperarousal. I put the dosing on here. I'll often start in adults with like 0.05 milligrams twice a day and then work up from there. I just saw somebody today with PTSD that I have on 0.5 milligrams at HS for nightmares, but we worked up on that dose slowly. With all these medications, it's orthostatic hypotension and dizziness to be careful with, and that's the reason to kind of go slowly. Prazosin is pretty commonly used for nightmares and insomnia, And that's usually started at 1 milligram and then increased as tolerated every 3 or 4 days. The range is usually 4 to 6 milligrams, although I've seen some cases of people like taking 4 milligrams in the evening and then 6 milligrams at night. And it seems like the higher doses can be really effective, and taking them at night can help during the day with some of the hyperarousal. Propranolol is another good one. There's been some interesting studies using propranolol in emergency departments right after trauma, and some positive studies showing that that can decrease the risk of PTSD. But that again can help with hyperarousal during the day. And Topamax, I just started my first patient on Topamax for nightmares because I didn't have anything else to use. They couldn't tolerate the other things. So that's something else to think about. Benzodiazepines really to be avoided. Certainly if it's somebody who doesn't have a substance use disorder and you're using it, you know, a low dose to get them through a funeral or something like that, I could see it being appropriate. But there's this thought that we have state-dependent learning, so that if you're under the influence of benzodiazepines, it can actually impede your ability to process the trauma in an effective way, especially during therapy. So we try to avoid benzodiazepines as a rule. And Wellbutrin, bupropion, and mood stabilizers really haven't been shown to be effective. Buspar, I think, has been, I didn't list this on here, but Buspar, I think, has been effective. So if somebody's on an SSRI and you're not quite getting there, that would be probably a go-to augmentation strategy. So we had a great lecture a couple weeks ago by Holly on CBT, so I won't spend too much time on it, but this really is considered first line, either cognitive behavioral therapy or EMDR, both really helping people addressing the painful re-experiencing of the trauma and looking at cognitive and behavioral strategies that people have developed to avoid re-experiencing, and really helping people gain confidence and mastery so they can overcome the fear associated with the trauma. So with CBT, you know, it's difficult in a primary care setting, but a lot of, I mean, the first thing is support and safety and kind of basic needs after a trauma, making sure those things are taken care of, and then a lot of reassurance and psychoeducation, and letting people know that a lot of their reactions are very normal and should gradually get better. Having people in a safe environment describe an event more than once is a very sort of simple exposure technique that can be used in a primary care setting. For nightmares, I've had some luck with this, of having people record their nightmares, write them down, and change the ending of them. And I've found that to be a helpful brief intervention. In terms of EMDR, it's eye movement desensitization and reprocessing therapy. So basically what they're doing is the patient is focusing on the traumatic memory, usually when they're in a relaxed state, and they're visually tracking something bilaterally or experiencing a bilateral stimulus. And the whole time the therapist is supplying positive association and beliefs to replace the negative ones, maybe just saying that they're okay or that they're safe, or providing reassurance. And it's all about sort of reintegrating the memory in a less traumatic way. Debriefing, I thought I would mention because it may make things worse. This is just a single session kind of going over what happened, a critical incident stress debriefing it's called, and that can actually make PTSD symptoms worse, so it's really not recommended. So in terms of prevention, you know, I think in the early stages, it's really about early therapy, like I said, helping meet basic needs post-trauma, and then psychoeducation and support. And here are just a couple of resources. You can't really see the websites I put on here, but I think that they probably will show up on the slides that you have. I like the guidelines, Britain's National Institute for Clinical Excellence guidelines. I think those are more helpful than the American Psychiatric Guidelines. There is a screener, the PCL5, which is a 20-item self-report measure that you can use, and I put a link to how you could access that. But if you want somebody to fill something out and then use it to track the severity of their symptoms, to screen initially and then track the severity of their symptoms over time, that's a pretty simple tool to use. So that is it. Do we have any questions or comments about any of that? Holly, I'll bug you and see what you have to say about some of the therapy piece in terms of PTSD.
Sure. Well, I think that was a nice presentation, and I think that the psychoeducation and the normalizing around re-experiencing symptoms is so important, especially if you're a provider that sees someone pretty close to after the trauma happened. So people will be really frightened, of course, by having nightmares or the flashbacks. And that's all a really normal way that your body is trying to process the trauma. And I'll use that language, like your mind and your body, those nightmares, the re-experiencing, that's the way that your body is processing this trauma, and it needs to process it for you to get better. So not everyone develops PTSD. Actually, a decent amount of people who go through trauma never do, but they may have some of those re-experiencing symptoms. And it's the people who can kind of sit with that and process that will do better in terms of not getting PTSD. So I think just providing some basic psychoeducation about that can be really important. And in a primary care setting, you might be one of the, or a hospital setting, you might be one of the first folks that see people. When I worked at a burn clinic at a hospital, and the nurses would run to me like, he's having nightmares. And I was like, of course he is. He's just burned. He's just in an explosion. He's going to have some nightmares, and that's okay. And that's good. We need to support him around that. So it's more like Julie was saying, the avoidance of those symptoms that leads to more problems later on. So if you can provide that safe environment for them to be able to talk about the trauma and have a positive reaction. I think that's another thing with trauma, is that people go through a trauma, and what happens afterward is just as traumatic as the trauma is. You know, people have these extreme reactions or don't allow, there's a lot of stigma, or they don't allow someone to express. So having, you know, a supportive reaction can be really helpful.
What do you think, Holly, about the recommendation, like just in terms of exposure, maybe a primary care physician having the patient tell the story a couple of times? Do you have any thoughts about that as a strategy?
Yeah, I mean, I think that can be really helpful. And there are some brief protocols that I think are being researched right now in the literature on doing, you know, like 5-session prolonged exposure sessions actually in primary care. So it is being done. I think checking in with the person when they come in about like where their anxiety level is, and if they're able to tolerate doing that in the primary care office. Because of course we are exposing them to anxiety. We want them to feel some anxiety, but if they're at such a high level, I could see how that also might not be therapeutic, because while they're in this session, their anxiety level is going to need to come down for that to be therapeutic. Does that make sense?
Mm-hmm. Mm-hmm. Yes, thank you. Thank you. We have a couple of questions just from Zoom group chat, so we'll go to those now. The first one is, you mentioned 10 to 12 medications. Is there an accepted algorithm for sequence, duration, and or overlap of administration? So I'll give this to our pharmacist. Michelle, do you have a thought about that? Or
so I guess algorithm wise, in regards to sequence, usually first line treatment is an SSRI. So I would start there. Like Dr. Kelso was saying, either sertraline or paroxetine. However, any of them, fluoxetine actually has data as well, but I think any of the SSRIs are fine initially to treat. At that point, then I think it's more symptom management depending on what the patient is experiencing. So if they're having nightmares, adding on some Prazosin would be acceptable. If they're having more like acute daytime anxiety, considering some clonidine, as well as I see the next question is hydroxyzine, which I definitely think as needed hydroxyzine throughout the day is helpful for those patients who are having anxiety. In regards to the antipsychotics, I think antipsychotics have a very unique place in therapy with PTSD. If they're having any psychotic features associated with the anxiety with the PTSD, I think it's very appropriate. Usually more of like the hyperarousal symptoms, I think antipsychotics play a role. The hard thing with antipsychotics is that they have a very limited data to support them, and they can actually sometimes worsen symptoms of PTSD, so they're not considered first line for monotherapy for treatment, but adjunctively they can help. Mm-hmm. Duration, you know, I've always considered it as like at least 12 months of treatment with the SSRI, and then if they're still having symptoms, it could be all the way through lifetime, you know, depending on their symptoms. Mm-hmm. I don't know what you think.
Yeah, I would agree with that. I think in terms of managing sleep, I think the first step is to maximize the dose if they're tolerating the medication. So if somebody's on the Prazosin and they, you know, are just on 3 milligrams, and they're tolerating it, but it's not really helping all that much, I would push the dose before switching, say, to clonidine. Mm-hmm. I'd probably try the Prazosin first and then the clonidine second, although clonidine could be used during the day, especially if somebody has a lot of hyperarousal and maybe they can't tolerate the hydroxyzine. There's a question about whether if people complain of more vivid dreams on Prazosin. I haven't seen that necessarily, although it certainly is possible. It's also possible that the dose isn't high enough. Mm-hmm. But there's so many things that really can help with nightmares. So if that's not working, I think clonidine is a good choice. 25 milligrams of amitriptyline is a good choice. So there's lots of other options. And you don't have to wait for weeks and weeks for the sleeping medication. Certainly if you're not getting much of a benefit after, you know, a week at a good dose, I would look at something else, because getting someone's sleep restored is one of the key things, I think, to getting them to feel better. Let's see if there's another. Most of my patients complain of headaches with Prazosin and stop it due to that. Have you seen that?
I have seen headaches. Yeah.
Mm-hmm.
I don't think it's as common. It's about probably like 10%. Mm-hmm. But more so the orthostasis and hypotension is kind of the rate limiting. I've also seen data, like you said, at higher doses, but all the way up to 10 to 15 milligrams at bedtime if tolerated in some of the studies that look at PTSD and combat related in the VA population.
Yeah. So if somebody has headaches, you could try the clonidine instead. You could try amitriptyline or the propranolol. Interestingly, if somebody has headaches, maybe the propranolol, because sometimes that can help with headaches, would be an alternative. Mm-hmm. So, what else? Do we have any other questions from anyone on video or anyone on phone?
We have a question at PureView.
Great.
Hi, I was just wondering at what time would you attempt to discontinue Prazosin or clonidine for nightmares?
I think that I would say if somebody's doing well and they're under good control, I would just try to pull back on it and see how you do. And that would be kind of a conversation just to have with that individual. But I think after someone is sleeping well for a month or two, then it's a matter of just pulling back on it. I just saw someone today, the person I was telling you about on the 0.5 milligrams of clonidine, and she sort of on her own, I think as she started to feel better, developed more sedation in the morning because the hyperarousal was just naturally better, so she didn't need as much medication. So on her own, she had just kind of pulled back on her dose, and she was on 0.3. And we had just decided, okay, well, we'll just leave it there for now, and knowing that if her symptoms continue to improve, that we can maybe pull back or get her off of it altogether.
And kind of a little pearl about clonidine, trying to taper off over a period of time versus discontinuing, depending on the dose, you can actually see rebound hypertension associated with it at higher doses. So being aware of that.
There's a question about, are you concerned about abuse potential at all with clonidine? I haven't seen that at all. Has anyone else seen that? No? Okay. And then, okay, I think that's all our questions from the chat. Any other questions from video or from the phones?